the frontline landscape has changed so much. It's it's when I think back at the in 2000 late 2011 when we had bevacizumab entering into this space, and we were talking about what would be the most appropriate treatment for patients with advanced stage ovarian cancer. I don't think we had any, even dreaming how much it would change in a decade. But it really has. And so we've been fortunate now to conduct a number of trials in the frontline setting that are evaluating the role of PARP inhibitors with respect to the use of them either during chemotherapy, such as in VELIA, or using them in maintenance, as we saw with PRIMA and PAOLA-1. Obviously the VELIA trial has yet to be reviewed by the FDA, but we do have 2 recent approvals in the last month for all-comer patient population, which for niraparib, and for patients who are HRD, have evidence of HRD, for the combination of bevacizumab and olaparib. So very important trials. I think it's I can tell you that when we do real-world evaluation of primary ovarian cancer patients, we realize that a substantial proportion of patients are not tested for germline BRCA mutation. It's hard to believe, but it's the case. When SOLO-1 was approved, or when SOLO-1 was filed and approved for olaparib in patients with germline and somatic BRCA, we did see a shift in the importance of knowing what BRCA status was for these patients. So that was a very good thing for us. It started to put a premium on what we consider the standard of care for knowledge of the BRCA status, and we still believe that very strongly. What these nuke trials do is it also brings in another evaluation of the tumor microenvironment, which is homologous recombination deficiency in the absence of BRCA. And so the PAOLA-1 trial got an FDA approval for patients that have this deficiency signature that would allow it to be used in combination with bevacizumab. So, but they bring a little different, flavor as to how we should approach frontline patients. And this is something that we're continuing to debate. There's a lot of activity in the chat, in our social media about like what's the best approach. I think that one of the factors that will continue to be discussed particularly as VELIA comes into this equation, and that's that when you make your decision for the use of either a PARP inhibitor with respect to VELIA or bevacizumab with respect to PAOLA-1, you've kind of cast the treatment algorithm at that point. And so it makes the later or subsequent discussion about whether I should use a PARP or not almost moot because it's already been decided. But if you're not a big believer in either using PARP inhibitor with chemotherapy or using bevacizumab, then the next kind of equation will be, well, do I use niraparib or olaparib, depending on if they're germline or somatic positive, in patients who've achieved a response to their induction chemotherapy. So you can see it's starting to get pretty complicated now with all these options and the differential alignment of the biomarker to the regimen.